All right, so I will go ahead and get us started. Thank you for joining. My name is Emma Mitchell. I am the program manager for Morgan Cares, which is housed out of Morgan State University. And I have the pleasure of moderating the first portion of today's session. So I'd like to thank everybody for joining us, for our speakers, our panelists. Today is the fourth event in a series of educational programs that are the result of collaborations between multiple groups at Morgan State University and Johns Hopkins University. Together, these programs are designed to increase community awareness on topics related to aging, Alzheimer's disease, and related dementias, and to provide information about treatments for individuals with memory loss and to highlight the importance of diverse participation in research. We will have two parts to today's event. The first will be a presentation that will provide an overview of Lecanemab, the most recently FDA-approved drug for early Alzheimer's disease. The overview presentation will be given by Dr. Barry Greenberg, and he'll tell us a little bit about how the drug works, the results of clinical trials, testing the efficacy of Lecanemab, possible side effects, and a few other topics as well. And the second portion, following the overview presentation, will be a moderated panel discussion where two dementia experts will answer questions about Lecanemab, both from the questions that you submitted through your event registration form and then also live questions from the audience. And we'll open it up to close at that point. I just want to, before diving into the first presentation, acknowledge our event organizers. This event is presented by the Morgan State RCMI Ascend and School of Computer, Mathematical, and Natural Sciences, and is co-sponsored by Morgan Cares, which is the community engagement core of the Center for Urban Health Disparities Research and Innovation at Morgan. Also, the Johns Hopkins Alzheimer's Disease Research Center and the Johns Hopkins Alzheimer's Disease Resource Center for Minority Aging Research. Throughout this session, if you could please put any questions that you may have in the chat box or save them until the end of the presentation, we will have time to address them. And please also keep your microphone muted during the presentation and panel discussion. As I mentioned at the beginning, this session will be recorded and shared with all registrants following the session. So I'll go ahead and introduce our first speaker, Dr. Barry Greenberg, who is an associate professor of neurology at the Johns Hopkins University School of Medicine. Dr. Greenberg has been involved in Alzheimer's research and drug discovery since 1985, holding a series of positions internationally in the US, Sweden, and Canada. This has included positions in biotechnology and the pharmaceutical industry, as well as university settings. Dr. Greenberg brings a multifaceted perspective on Alzheimer's disease and an international reputation drawn from hands-on experience, ranging from basic research through human studies. We're thrilled to have him speaking today, and he'll provide an overview of Lecanemab. So Dr. Greenberg, I'll go ahead and stop sharing and you can take it from here.
Thank you very much. Let me get this going. Can you see my slides?
We can see the PowerPoint view.
Yeah, but I can't get behind that. Hold on a second.
Take your
There's
time.
a banner. I can't get to the slideshow because my mute button is right above there. Let me see if I can move that. There we go. Slideshow. How's that?
I think we're still seeing your screen with the PowerPoint.
Okay. How's that?
Yes.
Perfect. Good to go.
Okay, excellent. I want to thank Morgan Cares at Morgan State University. I'd like to thank the ADRC and the AD Rickmar at Johns Hopkins. Thank you for inviting me to make this presentation. And I'll move on with it. The overview that I'll be providing I'll be giving you some background, general background. I'll be talking about the clinical trials and outcomes for the Lecanemab studies, the FDA approval of the drug, the payers' decisions, specifically CMS, Medicare, and the Veterans Administration. There'll be a bit of a discussion on clinical meaningfulness and then a summary and future directions. It all started in 1906 at the Tübingen meeting of the Southwest German psychiatrists. You see on the top left a picture of Dr. Alois Alzheimer. His first patient was a woman by the name of Auguste Deter. She had an aggressive form of dementia with a lot of agitation attached to it. And when she died, Dr. Alzheimer removed her brain and took a look under a microscope with existing staining techniques at the time and made the drawings you see on the right-hand side, which, as we know, with more modern staining techniques, correspond to the neurofibrillary tangles, which are one of the pathological hallmarks of the disease. These occur within affected neurons intraneuronally inside the cells, and outside the cells, amyloid deposits, amyloid plaques. And this is going to really be a topic of the most of the discussion today. Alzheimer's disease has a long pre-symptomatic phase, which provides an opportunity for treatment and prevention. Nearly all of us have amyloid and tangles in our brains once we reach middle age. It's the amounts and the rates of accumulation which contribute to whether we develop Alzheimer's disease. Lecanemab targets the amyloid deposits, but in an interesting way. A beta is the name of the peptide, the protein that it makes up the core protein of the amyloid deposits. It's a naturally occurring functional neuropeptide. It's secreted as a single molecular monomer, depicted here, but also evolves through various conformational states that range from oligomers to protofibrils and ultimately to insoluble fibrils that comprise the amyloid deposits. Lecanemab is a humanized monoclonal antibody that selectively binds to A beta protofibrils. Then these are thought to be the most toxic form, and it initiates the clearance of both protofibrils and amyloid plaques, amyloid deposits. Every phase 3 clinical trial is given a name. The sponsor of this trial was Eisai in partnership with Biogen, and it was named Clarity AD. It was a global placebo-controlled, double-blind, parallel group randomized study. You don't have to remember any of that. The patient population was about 1,800 subjects, about half of whom were in the United States and half of whom were outside the United States. And these are subjects who were diagnosed with mild cognitive impairment or mild dementia and determined to be amyloid positive as part of the enrollment criteria for the trial. They were randomized half to treatment and half to placebo. And the treatment was an intravenous infusion of the antibody every 2 weeks, biweekly intravenous infusions. 3 phases were randomization phase, open label extension phase, and their optional longitudinal sub-studies. This was the real trial, the randomization phase, and the primary outcome measure, which I'm going to be talking about more in the next slide, is the so-called CDR sum of the boxes, Clinical Dementia Rating Scale. And the outcome was a change from baseline at enrollment to 18 months following the treatment phase of the trial. Key secondary measures were amyloid deposits in the brain with imaging called positron emission tomography, PET scans, amyloid PET, and other cognitive and functional measures, which I'll be naming later. In the open label extension phase, this follows the 18-month trial when subjects who wish to continue on the drug or who were on placebo and would like to go on the drug all know that they're on drugs. So that's why it's open label. The primary outcome measures for this extended trial are the number of participants with treatment emergent adverse events. And I'll be talking about these side effects in a short while, as well as further change after the 18 months in the primary outcome measure, the CDR sum of the boxes. The optional longitudinal studies are focused on measures of amyloid in the brain, the neurofibrillary tangles, the tau PET imaging, CSF, cerebrospinal fluid biomarkers, and the sponsor is also testing a subcutaneous administration, which alleviates some of the burdens of the biweekly intravenous infusions. This is a slide from Eisai, and this is really the money slide here. There are going to be a few money slides here. The CDR sum of the boxes is a patient and caregiver interview, and it rates 6 cognitive and functional domains that are listed here: memory, orientation, judgment and problem solving, community affairs, homes and hobbies, and personal care. And what you see in this primary outcome, this line, bottom line here, this was the progression of the individuals who were on placebo from baseline to 18 months. The line above it in green, if you can see it, is the depiction of the subjects who were on drug. And there was a statistically significant separation of drug versus placebo at 6 months, and this differential continued to widen to 18 months. What is seen here that's very important to understand is that all subjects were progressing with their disease. It's just that the subjects who were on drug were progressing more slowly. And this graph showed a 27% slowing on the CDR sum of the boxes, and with an increased magnitude of separation over time. And this effect was seen across all of the domains of this measure. Equally important to the subjects and their care partners are activities of daily living. This is another battery called the Alzheimer's Disease Cooperative Study, MCI, Activities of Daily Living Scale, from baseline to 18 months. This is a battery that's rated by the family or a caregiver that has 24 items assessing daily activities. And you see again, subjects on placebo and subjects who were on drug, and an increasing magnitude of change, of difference between these progressive changes from 6 months to 18 months. And this shows, this is a slide that shows that the drug was hitting its target. It's removing amyloid from the brain, and substantially, I mean, completely moving amyloid from the brain. These were subjects who were on placebo, and you could see no change in the level of amyloid deposits in their brains through the 18 months of the trial. These were subjects who were on drug. There was a highly significant difference as soon as 3 months on drug, which continued to progress until there was essentially no amyloid left by 18 months. And this line at 30 is considered actually the threshold of positivity on these PET scans. And this just shows what the PET scans look like. These are subjects who are on placebo. These are subjects who are on drug. Baseline in both cases, no change for those who are on placebo, and basically removing the amyloid. For those of you who are familiar with this sort of picture, by 18 months. Somewhat stunningly, there were also changes in Alzheimer's fluid biomarkers that were consistent with the disease-modifying treatment effects. As expected, since this was an amyloid-targeted drug, there were changes in the A-beta, the amyloid core protein, the peptide, that were consistent with the removal of amyloid from the brain. And this was both in the cerebrospinal fluid, lumbar puncture, spinal tap, as well as in blood. There were also changes in other biomarkers that were consistent with a reduction in the rate of change in Alzheimer's progression. And these include markers of phosphorylated tau, total tau. Tau pathology is seen on PET scans, a marker of inflammatory response in the brain, the so-called glial fibrillary acidic protein, or GFAP, that is secreted by astrocytes in the brain, and a marker of nerve cell dysfunction. This is a nerve terminal synaptic marker called neurogranin, as measured in CSF. All of these changed in the direction that was expected for a disease-modifying effect by simply targeting amyloid. Now, let's talk about side effects. There were two most significant side effects that were part of this trial. The first are infusion-related reactions. Just to orient you, these are graded in grade 1, grade 2, mild, moderate, and severe, grade 3 to 4. So mild is grade 1. There's notable discomfort, but no disruption of normal daily activity. Moderate, grade 2, there's discomfort sufficient to reduce or affect normal daily activity. And severe, grades 3 and 4, are incapacitating. These could be systemic. If you've ever taken niacin and you've gone into a full body flush, you know what that feels like. What is noted is that of the 897 people on placebo, 898 on drug, there were these mild and moderate infusion reactions in some subjects on placebo. It was more prevalent in subjects who were on drug. There were 7 severe reactions out of the 898 among those on drug. To summarize this, the infusion-related reactions were largely mild to moderate, grade 1 to 2, 96% of them, and occurred on the first dose, and most of them occurred only once. About 40% of the subjects received preventive medications, things you commonly are familiar with, acetaminophen, antihistamines, hydrocortisone, for an infusion after experiencing the first infusion-related reaction. The recurrence rate was the same regardless of whether or not they received the preventive medication. 6 of the 7 severe infusion reactions occurred with the first dose. The other side effect to be aware of are so-called amyloid-related imaging abnormalities, which have been musically termed as ARIA. 2 kinds of ARIA: ARIA-E, which is with edema, so it's swelling in the brain, and these are seen on brain imaging, MRI imaging, when they're not symptomatic, and they're also seen on brain imaging when they are symptomatic. ARIA-E is edema. ARIA-H is microhemorrhages in the brain, also seen on MRI. The symptoms, the mild symptoms and severe symptoms, are listed here. Mild are headache, confusion, visual changes, dizziness, nausea, and difficulty with gait. Severe reactions can include seizures, encephalopathy, stupor, and focal neurological deficits. So the ARIA as a side effect can be asymptomatic, seen only on MRI, or symptomatic, seen on MRI and with symptoms. These are generally mild to moderate and resolve within 4 months of detection. 17% of the subjects on lecanemab exhibited ARIA-E or ARIA-H, 9% of them in the placebo group. So this can happen even if you're untreated when you're in this patient cohort. They were both more common in carriers of 1 or 2 ApoE4 gene forms. And to explain that, the apolipoprotein E exists in 3 flavors in humans: E2, E3, and E4. The normal allele, the normal form, is E3. Individuals who carry an ApoE4 form have an elevated risk for developing Alzheimer's disease, particularly if they contain 2 copies, or as it's termed here, homozygotes. There are 2 of these genes that are carried in our DNA. You can be both the same or different. It could be an E3, 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 E4, E4, E4. Now, the reason we know, one of the reasons we knew this was a risk factor for Alzheimer's disease, in addition to a large number of other studies, is that the prevalence of an E4 gene form is 17% in the overall population, but about 50% in subjects with Alzheimer's disease. So it's clearly a risk factor. If we look at the subjects who were in the Clarity study, the phase 3 trial, 53% carried 1 copy of ApoE4, which is consistent with the 50% in the general population in AD subjects. 16% carried 2 copies. And these individuals were at elevated risk for the side effects. And I'll come back to that. This is also a slide from ASI, the drug sponsor. And this just demonstrates that protocols exist for diagnosing and monitoring ARIA in the event that it occurs. Asymptomatic subjects, the information is outlined in red. Symptomatic subjects are outlined in blue. If someone is asymptomatic, and so the ARIA is only determined by a brain scan, by an MRI. If it's mild ARIA, E or H, the subjects can continue treatment with monthly MRIs to monitor. If they continue treatment, they can discontinue monthly MRI if the ARIA resolves or stabilizes. In the event that the observations in brain scans are severe or moderate, then these individuals move over to the protocol on the symptomatic side. In this case, treatment is suspended. There's ongoing clinical assessments, monthly MRIs to monitor the levels of either ARIA-E or ARIA-H. And if the MRIs show a resolution or a stabilization and the symptoms resolve, the treatment with lecanemab can be resumed if agreed to by the subject. So this is a standard protocol that was developed to diagnose and monitor ARIA. Now let's move on to the regulatory decision by the Food and Drug Administration. Accelerated approval was granted last January 6th, and this was based on the earlier completed phase 2 trial that preceded the Clarity trial, with the results that demonstrated clearance of amyloid from the brain. And it was approved for treatment in patients with mild cognitive impairment or mild dementia and confirmed amyloid pathology. And these were the same criteria that were required for enrollment in the study. And the reason that was maintained is that there was no data to demonstrate effectiveness or safety for initiating treatment earlier or later. So that was the approval regulation, the accelerated approval by the FDA. They considered the drug to be generally well tolerated based on the severity and incidence of the treatment-related adverse events that I described to you. And the first prescription was written on January 23rd. Full deliberations will be based on a consideration of the clinical outcomes demonstrated in the phase 3 Clarity trial data. The FDA Advisory Committee will be meeting on June 9th, and the final decision on full approval or otherwise is anticipated in early July. And there's your drug. It has been trademarked under the name of Lecanemab. January 6, 2023, the second drug approved in the US for disease modification for prescription use. What about the payer decisions? CMS, the Centers for Medicare and Medicaid Services, Medicare, and the Veterans Administration. The drug isn't cheap. It's priced at $26,000 per year for the drug alone, plus additional costs for safety monitoring. That drug cost will be reduced to $15,000 per year, approximately, in lower dosing for a maintenance phase once amyloid is cleared, as per announcement by Eisai, the drug sponsor. Medicare currently limits coverage for amyloid immunotherapies only to subjects who are participating in randomized controlled trials. But the agency noted that if full approval is granted by the FDA, that coverage will be extended for patients who enroll in a registry that tracks their disease. Now, to be a little bit more specific about what is meant by a registry, the example that's being used is the so-called ALZNet, which is a voluntary provider-enrolled patient registry hosted by the American College of Radiology. And it's a collective of organizations to track all the benefits and harms that these drugs deliver in clinical practice. And the purpose is important, is to determine how the effects of the drug change over time, who responds best, side effect tracking, and how well the therapy works in diverse real-world populations. And I'm going to be coming back to this concept of a registry a few times during the rest of the talk. The Veterans Administration has already agreed to coverage for veterans in early stages of Alzheimer's disease, except for those who carry 2 copies of the ApoE4 gene. But we have an issue, and that's the demographics of the trial. And this is classic in clinical trials and frankly, most observational studies in the Alzheimer field. And what I've highlighted here are the race distribution. What you see in the total trial, the international trial, is that about a little more than 3/4 of the subjects who were enrolled in the study were white. About 95% of them in the United States were white, with far fewer numbers, and arguably unrepresentative numbers, of Asians, Blacks, other racial groups. The Hispanic Latino, this trial did a little bit better than previous trials. Almost 1/4 of the subjects were Hispanic or Latino in the US trial, about 13% in the global trial. Now, what are the issues that we're facing here? The prevalence, the genetics, copathologies, comorbidities, biomarkers, risks, health disparities, and cognitive functional assessments have been shown to differ among races, ethnicities, sexes, and genders. That's a big statement. Racial biases have been identified in cognitive batteries that are used to diagnose mild cognitive impairment in early Alzheimer's disease. Biomarkers differ to varying degrees among racial groups, including amyloid PET, the PET scans for amyloid in the brain, and the impact of carrying the major genetic risk factor, ApoE4. The exquisitely defined enrollment criteria in clinical trials are variably representative of the far more diverse general population. This is a big problem. The impact is that the outcomes that have been defined by a largely homogeneous white population will differ to varying degrees among other participant groups, which remain to be studied. So what have we learned about the effect of this drug in Alzheimer's disease? We've learned basically how it affects people who look like me, white individuals of European descent. What's the risk benefit? Who should be exposed to the drug? The answer to that is we don't know. So this is, again, part of the importance of registries for understanding results in clinical practice if the drug actually makes it into clinical practice. Because only through accumulating those data will we be able to ask those questions, unless other trials are designed and conducted, which is a big time sink to the development of a drug for the general population. Now let's get into, and I'm not excusing that. I'm not trying to minimize that. Let's talk a little bit about clinical meaningfulness. This is another important aspect to the trial outcomes. The rhetorical question is statistical significance the same as meaningfulness for patients and families? Little background, the CDR, which was the primary outcome measure, is an 18-point scale, but it's not a full 18-point scale. There's a narrow range within this population. The Clarity AD trial demonstrated slowing of progression by 27%, as I pointed out earlier, which is equivalent to almost a half a point on that scale. At this mild stage of the disease, small changes may reflect substantial differences in people's lives. So, for example, a half a point difference may distinguish between slight benign forgetfulness and moderate memory loss that interferes with everyday activities, including engagement in community and personal affairs. The activities of daily living, 37% difference for MCI, may distinguish between doing a task independently versus requiring assistance. Long-term follow-up is needed to confirm the additional benefit beyond the 18-month evaluations in the clinical trial. Remember, the differences were expanding. And these will come from open label extension studies and from studies, registry-based studies in the heterogeneous clinical practice, with adjustments for implementation that will be required in order to make that happen. Now, is clinical meaningfulness in trials the same as for individuals? Well, it's not exactly the same thing. And here we get into the concept of that's being addressed a lot more in the recent published literature, and that's the concept of distributive measures versus anchored measures. So let me tell you what that means. Distributive measures represent the differences in change across treatment groups and trials. So in this case, the placebo versus the drug. It's important for demonstrating treatment effects in placebo-controlled trials. And the pre-specified outcomes, the primary outcomes that the drug sponsor negotiates with the regulatory agency, the FDA, target potentially meaningful changes, but they're group changes. They lack insight on the number of subjects in each group who responded to the intervention or the degree to which they responded. Anchored measures, on the other hand, anchored measures of cognitive change can better address individual responses. This is a rapidly expanding approach to analysis with ultimate potential for relevance to clinical practice. It'll require retrospective analyses of trial data, evaluating the change of individual subjects on treatment or placebo over time. Now, from a research perspective, appropriate sets of anchors will depend on the stage of the disease. So this is actually being addressed pretty actively right now. Analyses of progression from baseline over time will inform patient and care partner discussions with their doctors regarding the likelihood and the magnitude of benefit associated with a delay from one stage of disease to the next. and it has the potential for reducing the biases in cognitive measures or biomarker analyses inherent to reliance on distributive measures, since the change from baseline is measured for each individual subject. Again, this speaks to the importance of registry-based analyses. So where are we in treating and preventing Alzheimer's disease? This is actually a remarkable moment in the history of Alzheimer's research. It's a potential disease-modifying therapeutic agent that permits us to ask the key questions raised in discussions such as this one. We couldn't even have imagined having a presentation like this 3 or 4 years ago. Some patients in the trial undoubtedly benefited. We need to understand better who, why, and how well, and ask, if this worked in this trial, who will it work for in clinical practice? And the flip side of that coin, who will face unacceptable risks? We don't have the full answer to that yet. Again, it gets back to the demographics. Slowing disease progression may create opportunities. This is an important consideration, because I hear people say, "Oh, it's such a modest change in cognition. How can this be considered a drug?" Well, the fact is, it slowed disease progression, and if that holds up, what it does is it creates opportunities for even more effective combination therapies with other drugs. Combinations with drugs that otherwise might not work, but in the context of slowing disease progression, might actually contribute to a better therapeutic outcome. And combination therapies are very common. I take 2 antihypertensive drugs, for example, every day. Ultimately, this will require extended treatment in the more heterogeneous general population, which is why the requirements for registry-based analyses will be so important. And so, summary. Lecanemab cleared amyloid from the brain like a vacuum cleaner. The Clarity trial demonstrated modest but statistically significant benefit on all cognitive and functional endpoints across the trial cohort, that trial cohort at 18 months. It currently requires demanding biweekly infusions and safety monitoring, including brain scans, MRIs at baseline and before the 5th, 7th, and 14th biweekly infusion, and at 1 year for individuals who carry an ApoE4 gene form allele, in whom side effects are more common. Appropriate use recommendations have been developed and published, including protocols for managing adverse events. There have been recommended exclusions. I can get into this a little bit more later if you want. But recommended exclusions include subjects who are taking anticoagulants, those with 2 copies of the ApoE4 gene, those with severe vascular disease, clotting disorders, or pre-existing strokes or seizures. To be determined, what to expect if race and ethnicity differs from the trial subjects? Big question. And the decision to start and stop treatment is hard. Lecanemab doesn't stop progression, as I pointed out earlier. It slows progression, which may be difficult to assess on an individual basis. But again, we face this in a lot of different medical disorders. Like I said, I'm taking a couple of antihypertensives. Will that extend the period of time between now and when I might experience a stroke? Don't know that. We assume that it will, based on a compendium of data. The similar compendium is being developed for Alzheimer's disease and dementia. The decision should be up to the patients in consultation with their physicians and their care partners, who should be fully informed and understand what they're committing to undertake and the risks that they're taking. Last slide, my parting message. The Alzheimer research field remains committed to learn what it can from this moment to deliver safe, effective, and affordable therapies. There's a continued urgency to understand the early phases of Alzheimer's disease in diverse populations, how to treat it, and how best practices may differ among individuals, racial groups, biological sexes, and across genders. Many biological targets and mechanisms remain to be explored. Combination therapies will likely be critical to treat Alzheimer's disease effectively, as in other major diseases. Different drug combinations together with lifestyle modifications may be appropriate for different individuals. And this is why continuing and expanding research studies is so critical. And the landscape of doing that may change a little bit, may change the strategies a little bit with an approved drug on the market. But that doesn't mean that we don't do it and do it strategically. Ongoing willingness from generous and selfless research subjects to engage in clinical investigations is the key that will unlock the door to the ultimate achievement of preventing and treating Alzheimer's disease. And with that, I'm done. I'll stop sharing the screen and be happy to take questions or let it move on to the panel discussion.
Thank you so much, Dr. Greenberg, for that presentation. There were a few questions in the chat that were addressed by some other members, but we'll go ahead and continue on to the next portion, and then we can address any other outstanding questions in that Q&A session after the panel. So thank you again. Let me go ahead and share my screen here. All right, so I would now like to introduce our two panelists and our panel moderator. Our first panelist is Dr. Chadi Onyike, Associate Professor of Psychiatry and Behavioral Sciences at Johns Hopkins. He directs clinical and research programs focused on the epidemiology and treatment of frontotemporal dementias, young onset Alzheimer's disease, and other neurodegenerative disorders in young and middle-aged adults. Dr. Onyike received his medical degree from the University of Nigeria and a graduate degree in clinical epidemiology from the Johns Hopkins Bloomberg School of Public Health. He completed additional psychiatry and research training at both Johns Hopkins and the University of Maryland at Baltimore. Our second panelist is Dr. Paul Rosenberg, Professor of Psychiatry and Behavioral Sciences at Johns Hopkins and an Associate Director of the Johns Hopkins Memory and Alzheimer's Treatment Center. His research focuses on developing new treatments for Alzheimer's disease, with a particular focus on treatments for neuropsychiatric symptoms and sleep and circadian rhythms. Dr. Rosenberg trained in adult psychiatry at Tufts University and New England Medical Center and the geriatric psychiatry at McLean Hospital. This panel will be moderated by Ms. Nicole Onque. As the child of an Army officer, Nicole grew up exposed to an array of cultures and witnessed firsthand the vast disparities in education, wealth, and opportunities that exist across integrated communities. At a young age, she developed a desire to address those gaps in ways that could significantly improve the lives and outcomes of members of her community. Nicole holds a Bachelor of Science degrees in Psychology and Human Resource Development and a Master of Science degree in Instructional Systems Development. She has been a leader in the field of human resource development for over 20 years and has also been recognized for her philanthropic efforts. She is a mentor and passionate supporter of causes that help and empower women and girls. And she is a member of the Binti Circle, a caregiver support group for women of color. And since her father's diagnosis in 2017, she has served as an advocate for the Alzheimer's Association, as well as caregivers and families living with and fighting for a cure for Alzheimer's disease. So I'll go ahead and turn the floor over to you, Nicole.
Thank you, Emma, and thank you, Dr. Greenberg. We did have several questions that were submitted online by event registrants. So unless Dr. Onyike or Dr. Rosenberg have opening remarks, I would like to start with the questions that were submitted by the registrants, if that's okay.
I actually would like to make some opening remarks just to sort of give me my overall take on this. I think that this drug is an important step, but not a breakthrough. And my enthusiasm for it is somewhat lukewarm because the effect is not very strong. I think it's the greatest example I've seen where the patient and the doctor and the family have all got to put their heads together and weigh their feelings about the disease versus their feelings about the potential effect. The second thing I want to say is, although the drug is, and listen, what I mean is, I think the drug works. Do you see the air quotes? It works. It removes amyloid and it's associated with clinical improvement. But is it enough to make a difference? And I think that's where we really got to individualize treatment. The other thing I want to say is, right now, today, we're sort of in a regulatory middle zone. The FDA has approved, but no insurer is going to pay for this expensive drug unless the FDA gives a full approval. Right now, it's done something called an accelerated approval. which is a halfway measure. It means I can write a prescription, but Medicare won't cover, and no other insurer will. The FDA is going to make a decision on full approval in July, and they've got a panel which basically advises them in June. Most of my friends in the field predict it'll get approved, which is different than aducanumab last year. And I think I personally think the difference is that the data for aducanumab were very equivocal. You had a positive and a negative study. This one, you got a solidly positive study. Everything goes the right way. Then we have to see if Medicare reimburses. And I think that is a major policy issue. But I predict this drug will be available to people later this year. And I've been saying to my patients, whatever appointment you have with me after July, that's when we should talk. So I just wanted to kind of put it in perspective. A good start, probably not a breakthrough. I desperately hope it's not the last drug we get.
And so if I may make some remarks as well. Firstly, thank you for putting this together. And I think Dr. Greenberg gave an excellent summary, and Dr. Rosenberg has followed with some excellent points as well. I won't repeat what's been said, except to say that this certainly feels like a game changer in the sense that we've quite firmly moved from symptom-based interventions to this is essentially the culmination of an ambition to stop neurodegeneration as opposed to managing the symptoms. So it's in that sense inspiring, and we see where we go from here. Regarding the payment issues, the CMS, I focus on people who are younger when they develop the illness, typically before the age of Medicare. And so it will be interesting to see to what extent other payers besides Medicare and the VA react to any decision that CMS might make after full approval, which I agree with Dr. Rosenberg, seems very likely. So thank you again.
Thank you both for those remarks. As I said, I would like to begin with the questions that were submitted online. So to start, can you tell us who is a good candidate for lecanemab? Or on the flip side, are there individuals who are not good candidates?
Well, let me take a first stab at this. The drug was studied in what we would call very early Alzheimer's. And if you're looking at the fine print, try to ignore it. It says mild cognitive impairment or early Alzheimer's. In the real world these days, we know there's no sharp dividing line between the two. But keep in mind, these are people with very early disease. The second thing is it's likely that certain risk factors will cause us not to use the drug, but we're still debating the importance of those risk factors. For instance, ApoE. There's a gene called ApoE, and a certain form of this gene, E4, increases your risk of Alzheimer's. And you might have one E4 gene, you might have two. It doesn't really cause the disease. It actually causes the disease to occur earlier, but it's not the cause of the disease. A small number, a lot of the population has one E4 allele, over a quarter. A very small proportion of the population has two, because you need to get one from each parent, which isn't that common. The people with the two E4 alleles have a higher rate of side effects, and it's high enough that I suspect the FDA is going to caution against it, although probably not forbid it. The harder one are blood thinners. Lots of older people take blood thinners. And now that they've gotten safer to use, for instance, the blood thinner called Xarelto, a pretty easy drug to take. You don't have to get a lot of blood tests and so on and so forth. There have been 3 deaths in the Lecanemab trials, and they were 3 deaths from brain bleeds, and in each case there was something that increased the bleeding risk, either Xarelto, or in one case it was actually acute treatment for a stroke. We don't I don't know where we're going to come down on blood thinners. So I'd say the ideal candidate, and we'll find out what the FDA says. I expect them to have some more specific recommendations, and God knows we're going to need it. So I think the best candidate is someone who has very early disease. I think that's going to be defined. I think there's going to be some quantitative measures of that.
Mm-hmm.
But for me, the biggest thing is, how bad do you feel about the disease, and does it outweigh concerns about risk? That's a real personal decision. That's not even a doctor's decision. Listen, there's many things in medicine where a doctor can really have a strong opinion, okay? If you're in the emergency, if you have chest pain and you're in the emergency room and they think you're having a heart attack, I recommend you get treatment. I'm not gonna whiffle about it and say, they're the patient decision. I think we should have a conference to decide it. But in this case, I've never seen a decision so clearly patient-centered. I think it's going to depend on you weighing, I wish I had the scales, the scales of justice. There's a scale on each side. How much does your concern about the disease weigh versus how much does your concern about side effects? And I can tell you you take two people who have exactly the same functional level, and you can get totally different answers to this.
Okay.
How's that for a long answer to a short question?
Very helpful. Very helpful. You mentioned, I just wanted to follow up on this because you mentioned early onset and the fact that has not been clearly defined. So are we looking at the different stages that folks may be in?
Well, let me put it this way. When I say early disease, I mean clinically early disease. Most of the people who are going to take this drug are going to consent for themselves.
Okay.
Mhm.
They may well be functioning in many areas of life. They might still be driving. They might still be doing their bills. I guarantee you, if they are, their families are worried about them. And they are certainly using the toilet and dressing themselves and so forth. It's a narrow range. The thing you have to realize is when I say early clinical disease, the Alzheimer's process has been going on for 15, 20 years at that point. Spooky, but true.
Thank you. Dr. Onyike, did you have anything to
Well, I was just
add?
going to say, generally, so if we look at the history of memantine, for example, it was initially approved for very late stage disease, but then over time, there has been creep in terms of, there's been a broadening in terms of its usage. And as Dr. Rosenberg has mentioned, deciding where to draw the line will not be an easy thing, especially in the face of desire. And so I think the guardrails will end up being, payer decisions, what the payer will agree to do. And I anticipate that there will be efforts to define hard numbers, around scores on certain clinical instruments. Exactly where those lines will be drawn, we'll have to see.
Thank you. We had some of the additional questions about patient outcomes. So can you tell us how much benefit one can expect from the drug, for example, in terms of improvement in daily functioning or effects on quality of life?
Well, if we were to take literally the numbers Dr. Greenberg presented, we might expect that firstly, people decline in both treatment groups. So what we're really talking about is to what extent people decline, how much slowing do you get from taking this treatment? And right now the effect sizes seem rather small. It's not clear how they translate from group to individual. And in the real world, you're going to be contending with more complicated people, people who have heart disease, people who have a variety of other medical conditions. And in general, clinical trials data often are in danger of overestimating benefit because they're dealing with healthier people than who will actually receive the treatments in the real world. So I think the effect sizes are likely to be small. But this is where the registries, I think, will help us clarify things over time.
Thank you. And going back to the clinical trial results, Dr. Greenberg did touch on the fact that certain subgroups of the population weren't adequately represented, but do we know whether subgroups responded better or worse to the drug?
We know that we haven't found the subgroup that responds better. They were quite disappointed because this trial was large enough that it was powered so you'd be able to tell men, women, black, white, older, younger, kidney disease, whatever. There was enough power to ask those questions, but nothing really jumped off the page, meaning they didn't find a particular group that did better than others. They didn't find a particular group that did worse than others. Clearly, we don't know what that factor is. One of the questions had to do with, basically, does everybody have a 27% slower decline? And the answer is, of course not. There's a range of responses, and we'd love to deconstruct that. We'd love to know who's more likely to respond. Look, we were talking about diversity in trials, and this trial had lousy diversity. I'm sorry, I don't have a nicer word for it. We have many reasons to need inclusion and diversity, and it isn't just justice. It started with justice. That's the high ethical part. But there's some real practical parts. Blacks and whites have different responses to other drugs. Blacks have somewhat different risk factors for dementia, or sorry, Black Americans do. And Black Americans have higher rates of dementia, probably due to higher rates of vascular risk factors. So we're missing that. Someone else asked, is anything being done about diversity in clinical trials? I have to answer to NIH for every dollar I spend. And one of the first questions is, how is your inclusion? Mm-hmm. I'd say the field hasn't quite cracked that code yet. We're sort of working toward it. We're getting better. And it's more, the NIH funded trials tend to be doing better simply because NIH says, you are required to do this and we are going to monitor you for this.
Right.
Yeah, the efforts to diversify trials have not been very successful. One of the, I think, they have the NIH mandates, as Dr. Rosenberg has pointed out. I think that they've had limited success. The challenge is, going to require very serious outreach activity. But I think the aspect of outreach that does not receive adequate coverage is broadening where the clinical trials happen. Because right now, outreach is still requiring people to come to the ivory tower or to areas where, people from minority ethnic cultural groups do not necessarily gravitate to for care generally. And so it's going to become, I think, to really get there, we'll need some sort of knowledge and skills transfer to broaden exactly where these trials happen, where the recruitments take place.
Thank you both. And I'd like to discuss side effects for a moment. Were there subgroups who were most at risk for side effects? Do we know that? And can you talk further about the brain bleeds and what we know about the effects of brain bleeds?
The major risk factors, so the serious side effects are these so-called ARIAs, amyloid-related imaging abnormalities. There's two kinds. One is brain swelling, we call vasogenic edema, and the other is microhemorrhages, which we call microhemorrhages. And most of these are just MRI findings. To take the drug, you need to get a lot of MRIs. You need 3 MRIs in the first 6 months. That's a lot of monitoring. And the reason for those MRIs is to monitor for these events. Most of them have no symptoms, but a small proportion, I can't remember the number, maybe 25%, have some mild symptoms, usually headache, maybe feeling a little nauseous. And a very small number have more serious neurologic symptoms. They haven't told us how many are permanent. It is one of my big beefs with the industry on this. I'd like to know if you get one of these serious effects, how frequently does it last till the end of the trial? The answer is they're pretty rare. They're probably on the order of 1 or 2%. But this is what people want to know. I mean, when you sign a consent form, it tells you what's the worst that can happen. And we don't quite have that number there. Certainly people with 2 ApoE4 genes are at significantly higher risk of these side effects. And it's high enough. I am personally not going to give it to people, not going to give the drug to people who have these genes. And certainly people on blood thinners seem to have a higher risk of the microhemorrhages. Now, Corinne says, do we have an understanding of the long-term impact of ARIA? No. Next question. No, I'm joking. No, that's the important thing. That's the important thing is the ARIAs themselves usually no symptoms, and usually if there are symptoms, they're very mild. But the question is, how often is the rare event that they're permanent? And we don't have the number. In general, there's a general number of 2% for serious side effects. So not that small. I mean, if this drug gets given to 100,000 people, that's 2,000 people.
Thank you. Dr. Onyenke, anything to share, to add?
No, I think Dr. Rosenberg covered it.
Okay. All right. We do have some additional questions in the chat. Can we talk about the disadvantages of lecanemab? I don't believe we've covered that.
Yeah, it's a pain in the neck to take. It will, whatever the FDA approves, it's going to be a pain in the neck to take, or in the arm, really. You're going to need to get an intravenous infusion. That means they stick a needle in your arm and they put medicine in. Probably takes about an hour. You got to do that every 2 weeks. We're not sure of the duration, probably at least a year, but the studies went out to 1.5 years, but it may well be longer than that. You're going to need 3 MRIs in the first 6 months. You're going to need an amyloid PET scan or a spinal tap to determine that you have amyloid in your brain before you get drug. And there will be quite a few other hoops to jump through. So one of my main sort of things that I'm factoring in as I consider patients for this is how are they going to feel about the imposition in their lives? I've got a cousin with mild Alzheimer's. She's very concerned about the disease, but as soon as I described the treatment process, she flat out said, "I'm not doing that. I'm not going to all those. I'm not going to infusion center twice a month, every 2 weeks or twice a month." Mm-hmm. There are plenty of people who are going to feel differently.
And the frequency of infusion reactions can be expected to be high as well, and some of that will cause considerable discomfort.
It's pretty high. I just saw Dr. Greenberg showed some of the slides about infusion reactions. Actually, about a quarter of people who got lecanemab had infusion reactions. They're mostly very mild, but occasionally you have to give other medicines for the reactions. Mm-hmm. Here we're planning to use steroids if they get an infusion reaction, for example.
Thank you. We do have some additional questions. Can you tell us what is the outreach to get participation from the African American community? What outreach efforts are being taken at this time?
Well, one can't. Well, we know that the Alzheimer's Association is engaged in a concerted effort. There is, through a variety of mechanisms. One, for example, is the New Ideas Study. But there are other efforts that are happening. And then at the local centers, at Hopkins, for example, we for a long time had a standing community engagement efforts through a community board, a community advisory board, and a series of activities that we hold every year, with a community audience. And then also there are events within the community. We partner with local organizations as well. For example, the Jones family has an annual lecture series that many of us participate in that is directly facing the community. I think where there could be more work is in engaging, as I've mentioned earlier, practices, where people go to physician practices, physician groups, hospital groups, where perhaps you might get to be able to reach the physicians who see a lot of people from the minority communities.
Thank you. And in addition to outreach to minority communities, do we know how providers or how the government is going to handle access for low-income individuals, since we know the cost is prohibitive?
Flat out, I think very few people are going to be paying cash out of pocket for this drug.
Mhm.
It's not good enough that I would go crazy breaking the bank for it. And for that reason, the main impact on low-income communities is going to be copays.
Mhm.
There will be copays, and actually, most likely, the copays will be the problem for copays will not be the drug itself, but it might well be the MRI scans.
Mhm.
Will the government do something special? The answer is, if you have Medicare, you have Medicare.
Mhm.
But many people have Medigap to cover the copays and other costs.
Yeah.
So I haven't seen a specific government program for low-income persons, but many people who are low income are so-called dual eligible, Medicare, Medicaid, dual eligible. And I suspect those folks will have minimal costs.
Mhm.
But if you got to get to the infusion center, you got to get to the infusion center, whether it's your car or someone else's bus, so it can cost money.
Well, what I will say is that the people who are younger and who might be on Medicaid rather than on Medicare, or who might have a commercial insurance, might face more hurdles to get to the treatment. But I don't believe, and they might have higher copays as well. We'll have to see how it shakes out up beyond. I mean, it's clear what is likely to be the case for Medicare, but for people who will have to rely on commercial insurers, we don't know.
Speaking of inclusion, Inez points out that one thing that could improve inclusion is transportation. That's a good point. And in fact, we include that and fund that in almost all of our trials now.
Mm-hmm.
Excellent.
But we get to pick and choose who transports, and we usually pick and choose in a manner to improve diversity.
Okay. I do see that there are quite a few hands raised. If we have folks who want to ask questions, how do you want to handle that, Emma?
I think folks can just unmute one at a time, or if you want to call on people, it's up to you.
So there's a question about age. For example, if someone is 80, at the moment, there doesn't seem to be, other than the consideration that, the older one is, the more likely it is that they might be taking medicines, for example, blood thinners that might get in the way. But age per se is not likely to be a serious consideration for whether a person should or should not have the treatment.
I did have a follow-up question, actually. Do you know whether the trial was able to assess effects of the drug when it's taken with antipsychotics? I know my father, for instance, takes antipsychotics for agitation, as many Alzheimer's patients do. Do we know about the effects of those two things working together or counteracting each other?
As we like to say in academia, great question. No, we don't. I mean, we don't know. They didn't present anything on that. In general, like a typical trial, it's a clean population and they don't have a lot of other problems. They kind of don't represent the real world. And this is why I think it was Dr. Onyeki who said, these trials data have a way of showing you the best aspect of a drug. And then when you get it out in the real world, there's a lot of factors that might serve to dilute the effect. There's no a priori reason why this drug couldn't mix with most psychiatric drugs, but there wasn't a lot of data in the trial about that.
Okay, thank you. Another question coming in: to increase African-American participation, are there any discussions about offering it at CVS or equally well spread places, equally known, I guess, places?
I think the real question is whether we'll be able to do home infusions.
Yes.
CVS is not going to, I'm sorry, I shouldn't be so glib. They're not likely, because the infusions take at least an hour and there's the possibility of infusion reactions. I don't think this is going to be like when I got my COVID vaccine and I just, literally just waltzed into Harris Teeter and boom, they can do that. But this is a little more of a medical procedure. I think it'd be great if we could do home infusions, and they're certainly legal, ethical, and can be done safely, but you got to get someone to pay for them. And they do cost more than you going to the infusion center.
Okay. Another question, how is amyloid cleared, and do particles remain in the brain or do they disappear?
Dr. Greenberg can address that. He and I are good friends, so I can make him do it.
Thanks for the handoff, Paul. The antibodies are thought to clear amyloid through interaction with the surrounding microglial cells in the brain, where it's degraded. To quote Dr. Rosenberg, great question.
We're understanding more and more about how amyloid is cleared from the brain. And one of the issues is these side effects, these ARIAs, are likely the result of clearing amyloid. Not absolutely sure, but we think they're the result of clearing amyloid. And they probably limit how much drug we can give and how much amyloid we can clear. I think we would call it a rate limiting step. You can't give more drug because if you clear the amyloid too fast, you get too many side effects.
Okay.
Another point related to the cost, a point which should not be minimized. All of the anti-amyloid immunotherapy agents are being tested for subcutaneous administration, which is something that could be done by subjects in their homes. And it obviates the need for infusion centers or infusions. There's a risk to that, though. And the risk is monitoring for symptoms of ARIA and having a medical contact that can help support in the event of mild symptoms or other things which could go wrong that might be missed if you're doing it as a home administration. All of this it's the Wild West out there, and this is going to be part of the studies going forward. But I think subcutaneous administration is actually going to be the wave of the future with these drugs.
And just to translate into English for people, subcutaneous, it means it's like getting a flu shot. It goes under the skin. And we just hope it works as well as the intravenous. I mean, they started with intravenous because they know they can get the most drug fastest through that. But yeah, if we can move to the subcutaneous, I think everyone's going to choose that if they can.
Thank you. Another question for Dr. Greenberg. Where is the epitope target peptide sequence of lecanemab?
Well, it's in the middle somewhere. There's a history to this, and I was actually a participant in part of that history. There's a company in Sweden called BioArctic, and the founder of this drug is a fellow named or of this epitope that the drug targets is a very fine gentleman by the name of Lars Landfelt, who's in Uppsala. And it's a mutation in the A beta sequence of the amyloid precursor protein. And when it's released, this mutant has a tendency to form these protofibrils. And they raised the antibody to that protofibril structure and then developed one that was selective for that protofibril structure. So the actual epitope, it's a structural epitope, which this drug targets. And since nobody asked the question, and I'll be happy to ask it and answer it myself. The name Lecanemab, L stands for Lars, E stands for Eisai. Kembi in Japanese is roughly translated as beautiful, healthy, or elegant. So Lars is now one of the, I think, few very rich people in Sweden.
Thank you, Dr. Greenberg. Corinne has a question in the chat. She says, I've heard that some of the follow-up clinical trial data suggests that MRI measures of the brain volume are decreasing in individuals who receive the drug. Could you speak to these results and what possible interpretations might be?
Well, yeah, it remains unclear what the best, what this really means. It doesn't seem likely that this means atrophy or acceleration of degeneration. More likely it means, diffusion. It probably has something to do with shifts of water in and out of the brain.
I mean, in the big picture, with MRI brain volumes, they're pretty darn good for predicting who's going to get worse without treatment, but we really don't know what's supposed to happen with treatment. We really don't know, and different treatments give different results. So what Dr. Pettigrew is talking about is the fact that, well, we think that we want more brain and more brain volume, and therefore in these studies, sometimes you see less brain volume with treatment. I think it's actually the worst marker for, not a good marker for following the success of treatment.
Mm-hmm.
Okay. And we have a few more questions. In terms of future developments, can you speak to, are there any developments in the works for enhancing the effectiveness of the drug?
I personally think that the most important developments in the field are going to have a different kind of drug. The reality is a drug like this, as Dr. Greenberg points out, I love the term, works like a vacuum cleaner for amyloid. It really reduces amyloid, but we can see the clinical effects are fairly small. We've probably maxed out what we can do with amyloid. Even if we had a better drug, I don't think it would work any better. But there's another substance in the Alzheimer's brain, which is tau. And in order to get demented, you have to have changes in tau. We've made less progress, a lot less progress so far in finding anti-tau drugs. And most people I know in the field think that's where the field's got to go.
Dr. Onyeke, anything to add?
No, I think that's spot on.
Okay. And can we speak to, aside from the differences and the effects on race and ethnicity, if the study were better represented, what questions did this study raise?
Actually, I didn't quite understand the question.
Yeah.
Question about race and ethnicity, or questions about other things? I just didn't quite understand.
So we know that there are questions about whether there might be differing effects on patients based on their race and ethnicity because the study wasn't very well representative. So the question is, what additional questions did this study raise?
So there are a variety of subgroup analyses that the study is not able to, address. One of them is the one that's just mentioned, looking specifically at differences in effects by race, because the other groups are too small. There are not enough people to do those kinds of analyses. Dr. Greenberg in his presentation touched on questions about who exactly is responding, because what we're looking at in the data is an average across everyone. So you take everyone's scores and you say, here's the average from the class, but you actually don't know whose grades were worthy of a D and whose grades were worthy of an A. And in the real world, in the clinic, I either have the person with the D or the person with the A. And right now we don't have a way to know how to know or to predict for the person in front of us exactly what response to expect from this treatment. And so it would be good to have that kind of data. We'll be able to give better information to people to make the decisions, yes or no, about taking treatment.
Okay.
Can I add to that?
Yes.
I was just involved in a meeting earlier today, and this was a very active point of discussion. So the VA has approved supporting this drug, and the veterans represent a racially far more diverse group of individuals than anyone who was tested in a clinical trial. And the point was made that if a physician is facing someone who does not fit the individuals who were tested in the trial, that needs to become part of the discussion to inform the patient and the care partner, so that they're making the decision, understanding. So for example, if I'm an elderly Black man who walks in with a concern about my mild cognitive impairment, I need to be told by my doctor, this has not been tested in people like you.
Mhm.
And this is part of the risk that you must be willing to accept if you're going to go on this drug. And that's something which may need to be reflected as a policy decision by the VA, by the FDA and its labeling in the event that there's a full approval in July. This is just a fact of reality. You're shaking your head, Paul.
No, I agree.
Okay.
Okay. We do have a few other questions in the chat. Cherie says, how early do you as physicians test people for Alzheimer's, leading to being a viable participant? She says she doesn't know of many people who've had MRIs or PET scans in order to diagnose dementia. It seems people lean on confusion and memory issues, which could be caused by other things. So the question is, how early do you as physicians test for Alzheimer's?
If this drug is approved, we'll be doing more of the biologic tests like the PET scans. The problem is the PET scans are not covered by Medicare, who decided years ago that they didn't have enough clinical value to be worth the $5,000 to $8,000 per scan. Right now, if I want to test someone, I have to get a spinal tap, a lumbar puncture, and test for the chemicals in the it's the CSF, it's the fluid that surrounds the brain. It's actually a great test. It's probably better than the amyloid PET scan, tells you more. But you have to have a very skilled person put a needle in and take the fluid out. I'm currently starting to do more of those in preparation for the drug being on the market. In other words, we haven't been pushing as much for the biologic testing because we haven't yet had a decision to make with it. With this drug, we're gonna need the testing in order to use the drug. So you'll be doing more of it.
Okay. And to follow up on that question, another question is, are there other hospitals conducting testing? Johns Hopkins is the only name mentioned. Is it testing? Are we talking about testing or trials? Are there other hospitals running trials?
Well, let's just talk about the drug. I mean, the drug's going to be widely available, and just about any neurologist in the country will have it available if they have infusion centers and can get people to the MRI machine. Hopkins is not going to have any kind of monopoly on this. We do lots of research. I'm the Hopkins investigator, part of a prevention trial that's using the same drug. But we're prevention trial, you're giving it to different people. You're giving it to people who are cognitively normal and have amyloid in their brain. It's a whole different ball of wax, but it's the same drug. So yeah, I think everybody's going to be doing it.
Thank you. And there is another question. You just talked about availability, but this question, I guess, because the VA was mentioned that they have approved it for use. Are they currently administering the drug? Do we know?
I don't know.
Okay, thank you. I don't see any other questions in the chat. Do we have any other questions for Dr. Rosenberg or Dr. Onyike or Dr. Greenberg? Nope. Jasmine?
Hi, everyone. My apologies if you already covered this before I came in. Can you talk briefly about, I was reading in some of the study materials that there's can you speak about the relationship between coagulants and the treatment?
Yeah, like I said, you might have missed this, so let me repeat it. There have been 3 deaths that seem to be due to brain bleeds in the study. It's not a large number considering how elderly and frail the patients are, but there's a lot of concern that blood thinners like Coumadin, like Xarelto, which is widely used, that they increase the chances of these bleeds. One of the things I'm really waiting for if the FDA approves, one of the things I'm really going to be looking at with a fine-tooth comb is what are their recommendations on this? The field is not in consensus. I'd say everybody says there's a concern, but the question is, would we forbid people on blood thinners from taking it? Or we would say, go ahead, here's the risks, as they say in Latin, caveat emptor. That means buyer beware. I don't think we know yet where it's going to come down, but certainly it increases the risks of bleeds.
Thank you. When I read it, I was wondering about possible recommendations for that. So thanks.
And Diane Larson Freeman adds, doesn't aspirin thin the blood? Yes, but aspirin does it in a different way and doesn't seem to increase the rate of bleeds in this. This is entirely, it's a fancy word, but basically blood thinners that do this. Aspirin's an antiplatelet drug.
Thank you for making that distinction. Do we have any other questions for Dr. Rosenberg, Dr. Onyike, or Dr. Greenberg? Oh, it looks like Judy put a question in the chat. To repeat Hannah's question, we know many strokes are a factor in vascular dementia, but is it right that microhemorrhages, I'm not sure that is it right that microhemorrhages do not create the same risk? I'm not sure that.
We don't have the kind of data that would answer the question, what's the long-term effect of microhemorrhages?
Okay.
Only known about them for a few years. And we basically found out about them. There's two reasons we found out about them. One is we're using these drugs that cause microhemorrhages. And number two, we're using more powerful MRI scanners. With the less powerful ones, you wouldn't see any in most people. And now, guess what? Many, many people have a couple microhemorrhages and didn't know it.
Yeah.
Thank you. So that concludes our Q&A session. Dr. Rosenberg, Dr. Onyike, Dr. Greenberg, thank you all so much. Do you have any closing remarks for us?
At this point, sorry, I'll because we want to end at 5:30 sharp. So I'll close everything out.
Okay.
But I'd like to thank Nicole for doing an excellent job moderating for us. And thank you, Doctors Greenberg, Rosenberg, and Onyike. It's rare to find 3 specialists all in one place, giving us all this time, when you go for your doctor's visits. So we really thank you for spending time with us, answering questions that we had. And I'd like to thank the organizers also, Dr. Corinne Pettigrew, Anya Soldan, Christine Homan, Emma Schaefer, and Dr. Payam Shekatari. And so I like these organized things where the community gets to ask the questions. And I hope when we continue to do them, we'll be sure to join and to ask all the questions you want. And of course, I also acknowledge our funders, Ascend, RCMI, and all the institutions, Johns Hopkins and Morgan State. And there's some things in the chat if you need more information that I see that Corinne put in the chat. So thank you all so much for taking your time to join us today. I hope you learned something, that it's a start. When we do these clinical trials, you won't learn until you do them. So I heard very clearly that it's a start. It might not be great, but we have to start somewhere and it'll lead somewhere. So I look forward to hearing more about the drug being approved and new drugs being developed. So thank you all so much for joining, and have a great evening. And there's as you can see on the screen, there's a seminar coming up on Saturday, June 3rd, that we'll send out through Morgan Cares and other avenues. It's the 16th annual Holistic Health Seminar on Memory Loss. It's tips and resources for dementia care among generations. So it's another opportunity for us to get together again. So but we have all the participants, so we'll be sure to send this. And as we were told, this recording will be available for everyone who registered, because we did have 150, I think, people registered, but we had as many as 87. So all the people who could not make it will still get a chance to watch this. Oh, we were at around 180. Okay, that's good. And so we'll send a brief survey out in the next few days to see what you liked and what we can improve on when we continue to do this series. So I appreciate you all. Thank you. And
Thank
have
you.
a good evening.
Okay.
Thank you.
Thank you. Have a great evening on purpose.
Scotty and Paul, thank you again, and Barry.
Yeah, thank you all, panelists and Nicole and everybody who's taken part in this.
Yeah, Nicole, you're an awesome moderator.
Thank you, everyone. Take care.
Good night.
What'd you say, Emma? 87 at our high?
Yep, 87 at the height. Yeah, I think we had I just added the additional people who registered late to the spreadsheet. So it was 175 plus 11, so 186 total.
Oh,
Yeah.
just under 50%, which is really good.